Yes, we will ask, please, Dr. Tailor to come to the podium. Dr. Tailor is a consultant gynecological oncologist at Royal Surrey County Hospital at Guildford. And his speech is going to be about robotics in gynecological cancer. Thank you very much, Dr. Thank you very much.
Thank you. It's been a fascinating day. Although I don't speak Greek, I have learned so much today. It is amazing. The quality of the talks has been so good. It's been an amazing day today. I doubt whether I'll be able to live up to it, but I'll try. Nikos forgot to mention that I needed to give this talk in Greek, but he never taught me any Greek. So I should have learned Greek, as you will see. Now, how do I change?
For the file.
Oh. Okay. So I have nothing to disclose. So my talk, Robotics in Gynecological Cancer, it's a huge topic, and I can't really cover everything about gynecological cancer and robotics. So really, what I'm going to concentrate on is our own data from Guildford, because I can't really give you, I can't do this subject any justice by talking. In the 30 minutes that I have, I can't really cover everything. So I'll just talk about some general aspects about robotics. So Guildford is pointer? No worries. Yes. So that's where Guildford is. London is here, of course, as you know. We in Guildford, our unit is not very old. We started our oncology center in 2002. And since 2002, as you can see, we've had at least 6 Greek fellows. Nikos was one of them. And indeed, Dimitri was one of them. And our robotic program started in early 2010. So Dimitri missed out on it, but Nikos was our first robotic fellow. And he did very well because in 2002, when he was with us, he even won a championship. So an impressive display of robotic surgery skills took place. Even I took part in this championship, and he scored more than I did. That is my colleague, Simon Butler-Manuel. So it was the two of us who started that program, started gyne-oncology in Guildford in 2002. And then we had a third in about 2010, I think. So, as I said, I'll talk about robotics generally and its uses in uterine, cervical, ovarian cancer. And I'll really only talk about the Guildford experience, and I'll say a little bit about the cost and benefit. Stop me whenever you want me if you have a question. So really, Guildford, as I said, we started in 2002, started as 2 gyne-oncology consultants. We were both sort of laparoscopically trained. Simon was better laparoscopic trained than I was. I trained in Gateshead. Catchment size of 1.2 million. Our robotics started in 2010. We do about 150 robotic operations per year now. And we've just appointed our 4th consultant, and we have 4 fellows working under us. Last year we did about 340 major operations, about 130 for ovaries, 180 operations for uterine and cervix, most of which are robotically done. We did about 15 operations for the vulva. So uterine cancers is the commonest application for the robot, and it's especially useful in the obese population. It can also be applied, of course, in cervical cancer to do radical hysterectomies, trachelectomies, and lymph node staging. In our center, we do quite a lot of two-stage treatment, in that we do quite often we will do pelvic lymph nodes first, and then if they are negative, then go on to do the hysterectomy or the trachelectomy. And in our center, the trachelectomy, I don't do any trachelectomy, so they all go to one person. Simon Butler-Manuel does all our trachelectomies. So since 2010, we have gradually sort of increased our numbers, but they are now saturating at about 150. So we started off with the second generation robot, the Da Vinci S. The current model is the Da Vinci XI. In between S and XI is SI. So S, SI, XI. We now have two SIs. We've finished with the S. We've now got two SIs. I have no experience with the XI, but I think Yanis would. You probably have. Yeah, you work with the XI at Marsden. So we now do about 150 operations robotically at Guildford, and the three consultants have done these numbers. So majority done by myself and Simon. The third consultant, who came later, has done considerably less than us. So, the commonest operation, of course, is a hysterectomy. So I'll just very quickly take you through what a typical robotic hysterectomy is about, because people don't realize what it involves. They just look at the videos, and all they are looking at is the console phase of the operation. So a typical hysterectomy, of course, will involve securing the patient, because it's a very steep Trendelenburg of about 30 degrees head down. And if you're not careful, sometimes the patient will slip into the anesthetist's lap. Sometimes has happened. So the patient has to be secured. There will be an initial vaginal phase, where, of course, you prepare the vagina. You put the catheter in, and you may or may not use a manipulator. I myself don't use a manipulator. My colleagues do use manipulators, but I don't use manipulators. Then comes the laparoscopy phase, which is just your usual laparoscopy, insufflation. You place the trocars, and once you've placed the trocars, you ask the anesthetist to give you a steep Trendelenburg, and you remove the bowel from the pelvis. So that's the laparoscopy phase done. Then comes the docking. So what is docking? Docking involves bringing the patient cart near the patient and attaching. So there are usually 4 arms, 1, 2, 3, 4. One of them is a telescope arm, and you attach the 3 arms to the trocars that have already been placed. So that is end docking, where you put the cart in between the patient's legs. It becomes a bit tricky. It's easier, but it becomes tricky at the end when you're trying to take the specimen out of the vagina. So so that's end docking. We in Guildford now just do side docking. So we dock from the side. So if we need to get in between the legs to extract the specimen or do manipulating or whatever, it's easier to do it. Now, what many people don't realize about robot, perhaps it may be different with the XI, but with the S and the SI, the cart can only operate looking backwards. So if I'm the cart, the arms can only operate that way. Okay? It cannot operate that way. So in ovarian cancer, if I wanted to operate on the diaphragm or the omentum, that becomes difficult. I have to turn the patient around, put the head towards the cart, and then I may have some success. So it can be fiddly. So if you're just operating in one compartment, pelvis, then of course the robot is good. It also means that if you want to do para-aortic lymphadenectomy, you have to put the telescope a few centimeters above the umbilicus, so that you can have the appropriate angle looking at the para-aortic space. I don't know whether that's the same with the XI, or is it the same? So,
much easier with the XI.
yeah. So that is the limitation with the robot. So the robot, the docking involves bringing the cart, attaching the robot arms to the trocars. How many trocars are there? There are one telescope arm, and then there are three. Well, I certainly put in three trocars for the robotic instrument, so that's all the four arms. And then there is usually a fifth trocar for the assistant to put in any instruments or swabs or bags or anything like that. So there are usually 5 ports with a robotic hysterectomy that we do. So attaching the robot to the trocars, we will then insert the instruments, and the robot, the system will register them as having been activated. And then once they're activated, you connect the energy arm, energy, the monopolar, bipolar leads to them. So that's the docking phase. And then comes the console phase. So where you go and sit at the console, you look down the console, and you do the operation. You do the operation, you then remove the specimen, and you close the vagina. That's the console phase. And then once that is finished, you complete. So you undock, you remove the gas, you remove the trocars, and you close the ports. So that's a typical robotic hysterectomy. So it's usually said that, oh, robotic hysterectomy takes a long time. It's not true. So initially, our first 10 robotics, so this is back in 2010, yes, docking, meaning attaching, bringing the cart, attaching the trocars and all those sort of things, takes about 10 to 15 minutes. Now, we bring it down to about 6 minutes. So it can be a sleek operation. So within 6 minutes, the patient, the cart is docked. What about the actual console time for doing a hysterectomy? So, yes, initially, it takes about 2.5 hours to do just the console time. But once you get good at it, you can cut it down to about 1.5 hours. And that is your average one. And it is also dependent on how big the patient is. So if it's so even sort of BMI less than 35, even that is obese. But even then, you can bring the console down to 60. If it's a nice thin patient, 30 minutes. It's that quick. But even in big patients, you're looking at about 1.5 to 2 hours. So, the console time depends on, obviously, how big the patient is. Similarly, with radical hysterectomies, initially it was taking us about, 4.5 hours. Now it takes, certainly takes me just about 3 hours. Just the console time. So, has it changed anything for us? So before we got our robot, January 2010. So before we got the robot, our sort of database identified 72 operations for cancer. And our minimal access rate was actually only 18%. Less than 20% of our operations were being done laparoscopically for corpus cancers. And our length of stay was approaching 9 days, and median length of stay was 6 days. After the robot, so the first 5 years of robot, we did 380 operations for cancer, and our minimal access rate now went up to 65%. Our conversion rate fell to 3%. Previously was 4%. Despite the fact that majority of our operations were open anyway, so to say that even the little few laparoscopic operations that we did, we still converted 4% of them. But now with the robot, we were doing less conversions. Our length of stay fell to 3.8 days from 9 days, and our median length of stay fell to 2 days. Last year, so we did about 128 operations for uterine cancer, and our minimal access rate increased even further to 77%. And our conversion rate has dropped further. Our length of stay hasn't changed much. So for us, despite the fact that, well, Guildford did have a reputation of being a reasonable laparoscopic center, we were doing only 20% laparoscopic hysterectomies for corpus cancers, and that has now shot up to what, about 70, 3/4 of them being done laparoscopically. Now, these are very crude survival figures. Although the blue is robotic and the pink is open, I don't want you to conclude that robotic surgery is better than open surgery. No, it isn't, because the pink data, the open data, is historical data, meaning before 2010 mostly. So they have much better follow-up. So there is less censored data. So there is a lot of censored data for robotic cases, and that artificially brings the curves up. But essentially what I'm trying to show here is that robotic surgery does not compromise survival. So as I was saying, robotics is especially useful for obese population. In UK, about a third of uterine cancers are related to obesity. And if you look at the trends for obese patients, BMI more than 30, about 25% of women are said to be obese. In our cohort, 56% of women with corpus cancers were BMI more than 30. So more than half of what we are operating on are obese patients. Similarly, if we look at morbid obesity, BMI more than 40, about 3.5% of women in Britain are said to be morbidly obese. And our cohort, about 18% had morbid obesity. Our highest is about 72 that we have done. So minimal access surgery, we have heard a lot about that today. So I'm not going to go over this. I do very little laparoscopic hysterectomy these days. It's all robotic. Really, you would be able to tell me more about this than I can. I suppose the take-home message that we got even today from earlier talks was the risk of conversion to laparotomy, which is dependent on BMI. So this was the GOG study from 2009, and in that study, having a BMI more than 35, you were not even sort of eligible for the study. And for them, the conversion rate was about 25%. And this graph that they depicted was the predicted probability of conversion with the BMI. So at about BMI 35, they're saying 20% probability. There was another study from Europe that also looked at this and suggesting that the risk of conversion rises quite sharply with the BMI. Now, with robotic hysterectomy, like with total laparoscopic hysterectomy, vaginal access or uterine descent is not critical, but we do have to have a steep Trendelenburg position. Now, that does put give problems to the anesthetist, but the way we can help the anesthetist is that the robot will take majority of the weight. So we can now operate with intra-abdominal pressures of about 8 to 10 millimeters mercury. I don't know what you guys use for total laparoscopic hysterectomy. I presume it's about 15, I presume. But we can, with robot, we can go down to about 8. So the anesthetist is happy. And of course, we are operating, sitting comfortably at the console, so we're not necessarily getting too tired. Our conversion rate for BMI more than 35 was 3%, whereas if you looked at that graph, they were saying more than 20%. Now, this is what sometimes we have to contend with. Now, it is distressing when you come across this sort of picture. I suppose the most difficult bit about this that I find is actually the initial laparoscopy, getting into the peritoneal cavity. Once we're in the peritoneal cavity, then the robot takes over. You can usually do the hysterectomy. It's not easy, but usually you will be able to complete that. Again, I don't know how much of a challenge this is with conventional laparoscopy, but I'm sure it wouldn't be easy. Moving on to cervix cancers. Since 2010, we've done about, well, no, we haven't done. We've had 230 cervix cancers come through our unit. Of course, quite a lot of them have gone on to have chemoradiotherapy. But out of those 230, 9 just required simple hysterectomies. 2 required a simple hysterectomy and pelvic lymph nodes. Now, as I said, we do quite a lot of two-stage treatments for cervix cancer. So 42 women had robotic lymph nodes done first, and out of those 42, 25 then went on to have a robotic radical hysterectomy, and 5 had a robotic trachelectomy. Now, in addition to these 42, there were 36 who had one-stage treatment, meaning they had the radical hysterectomy and the lymph nodes done in one sitting. So in total, we had the 25 and the 36, 61 robotic radical hysterectomies. And we've had 5 plus 4, 9 robotic trachelectomies. So out of the 61 cervix cancers that we've treated, these are some of the problems that we've had. And these are all part of the learning curve that we had in the initial phases as well. So we've had 2 bladder injuries, 1 bowel injury. Again, none of these caused any long-term harm. There was a ureteric diathermy injury that we had. It was a visiting fellow who came from another center, who came to learn robotics, and inadvertently applied some diathermy to the ureter, and then she subsequently developed a UV fistula. We've had problems with bladder atony in about 8. In total, we've had 4 ureterovaginal fistulas, and we have had 1 vesicovaginal fistula at about 10 weeks. And we just don't understand how she developed a vesicovaginal fistula at 10 weeks, but it happened. So with our robotic radical hysterectomies, our median length of stay was 1 day. Our mean length of stay was 2 days. 5 patients have recurred and died. 4 have had recurrence but not died yet. And 52 have not had a recurrence. Now, how does that translate? So at the moment, this is what our figures look like for those that are treated by surgery. So about 90% 5-year survival. We've had 9 radical trachelectomies. We have not had any recurrences. As far as I know, nobody actually has tried falling pregnant. But as I said, these are not cases that I have done. They've been done by Simon. But we haven't had any pregnancies reported. But that may be because the patients themselves haven't really tried. This is the kind of specimens we can get with robotic hysterectomy or a trachelectomy. So they're obviously reasonable specimens. Moving on to ovarian cancer, I'll say very little about that. The only application that we use robot for in ovarian cancer is just for completion staging. We do not use it for advanced ovarian cancers or debulking surgery. So these are cases that others have inadvertently diagnosed an ovarian cancer, and we go in to do a completion staging procedure on them. And we've had about 25 robotic cases. 19 of them were invasive, 6 were borderline. 9 turned out to be stage 3. 14 were stage 1. 3 have since died. 7 others have recurred, and 2 were stage 1s. Now, there are people who have used the robot for advanced ovarian cancer, trying to debulk ovarian cancer. I'm not so sure whether that is going to catch on, but I suppose it's early days. As I said, the limitation of the robot is that it's only going to allow you to operate backwards, so to speak. So if you then want to go and operate on the diaphragm or the upper abdomen, you then have to turn the patient around. And whether you can get into the various spaces and manage to get all those nodules, I have my doubts. I wouldn't even go there myself. So, why would you choose robotics over conventional laparoscopy? Well, actually, if you are a very good laparoscopic surgeon, then you don't need the robot, okay? Because there is no advantage to your patient. If you're a good laparoscopic surgeon, there is no advantage to your patient. And you could even argue that laparoscopically, you could do it with fewer ports than 5. So just carry on doing whatever you're doing. Of course, in the long run, 5-10 years down the line, perhaps you might start suffering from neck and shoulder problems. My colleague Simon has had surgery on his shoulder. So I suppose that time will tell. Now, if you're an average laparoscopic surgeon or mainly an open surgeon, then certainly the robot will have its advantages because it will bring your sort of minimal access rates higher. And of course, it will help with the obese population, lower the conversion rates. Much quicker recovery. And perhaps there may be benefit for you in terms of less morbidity on your own shoulders and necks. So really, the benefits of robotic surgery, 3 main ones: very good vision, 3D vision, and you're sitting comfortably, so better ergonomics. And of course, you've got your wrists back, which you don't have with conventional laparoscopy. So there are other advantages as well. If you do operate with a tremor, then the tremor can be filtered out. Of course, The other bit is you're in complete control. You're in control of the camera. You're not having to tell the assistant point in that direction or point in this direction, or there is no assistant fatigue. The images are sort of consistently good. You are wasting less time cleaning the telescope. Less blood loss, and of course the learning curve for robotic surgery is much less than complex laparoscopic surgery. Coming on to cost, or disadvantages should we say, the main disadvantage of robotics of course is the cost associated with robotic surgery, and that of course is the equipment itself. In the UK it costs about 1.5 to 2 million pounds, and then there is annual servicing costs, which is approximately 100,000 pounds per year. And of course then the consumables. So if you imagine there are the three instruments, 5 ports, but 1 telescope and 3 instruments. Each instrument is approximately 250 pounds a go. And then of course there will also be the sort of sterilizing costs and all these other costs associated with it. So yes, cost is an issue when you're doing robotic surgery. And lastly, I mean, there was one study that Tom Ind from the Royal Marsden published recently on treating endometrial cancers with a robot, in that they compared their cost of treating endometrial cancers before and after their robotic program was initiated. So they had 130 before the robotic program and 66 after the robotic program, and they had a very in-depth study of their individual costs on each of those patients, looking at the ward, the high dependency costs, the staffing, the theatres, blood products, everything. And what they found was quite interesting, in that by introducing robotics, they managed to reduce the cost of treating endometrial cancer by about £1,000. So yes, it's costly, but it can, in the long run, have its benefits. So my last slide, just to say that minimal access surgery, which is what we have really heard all day today, should be the default approach for the treatment of endometrial cancers. Robotic assistance does have its advantages, but the main one really is with obese patients. So if you're a good laparoscopic surgeon, you don't need the robot. If, however, your institution already has a robot, the urologists have it, then you could, because if the main cost has already been incurred, then you may as well use it for gynecology, because the more the hospital uses the robot, the less the cost. So in the lifetime of that robot, it'll be more productive. So you may as, if your hospital has it, you may as well use it. Thank you very much.